So most of the patients present depending upon the depends on the virulence of the organism that is causing the infective endocarditis. As I told you, acute patient present more, they have more sicker course and they'll be more toxic. So fever is the most common symptom, which is not responding for any of the antibiotics unless we treat with culture specific sensitive antibiotics. And anorexia, weight loss, malaise, and night sweats they can have. And they usually on clinical examination we find heart murmurs, new onset murmur, or a change in the quality of the pre-existing murmur. You can appreciate. And some people they can have a petechia on the skin, conjunctiva, or oral mucosa, and they can have splenomegaly due to septic embolia causing splenic abscess or splenic infarcts. And sometimes they can have a right side endocarditis patient. Usually they'll not have any peripheral embolia because usually even if it is embolized, it goes into pulmonary artery. So they'll in those patients usually pulmonary findings will predominate. And in subacute presentation, usually they present with the flu-like symptoms and various vague symptoms like anorexia, low-grade fever, and as I told, retinal hemorrhages. The hemorrhagic spots within the retina are called as rod spots, and then the subungual hemorrhages are the, if you observe this nail bed, they're called as subungual hemorrhages. And some people can present with the intracranial with embolic stroke or cerebral abscess. They can present with ocular nodes. There are painful subcutaneous nodules in the pulp of the fingers, and something called as non-tender nodules, which are called genuine lesions. And they can have arrhythmias, and they can have a pericardial rub secondary to pericardial effusion involvement of the pericardium and the heart failure. They can have splenomegaly, and some people can present with abdominal symptoms. So various presentations will be there depending upon the presentation, like the virulence of the organism, and also the timing of the presentation of the patients. So whenever there is history of prostatic valve, so usually patient will present with they'll have an indolent course with a low-grade fever and there will be new murmurs they can have present with. Sometimes they'll be present, most of the time they'll present with a struck valve, that is dysfunctional prostatic valve. So whenever there is a patient with a prostatic valve surgery earlier, whenever they present with a long-standing fever, not responding for our regular antibiotics, and the patient is having any new onset murmur in those patients who are already operated, or any clinically pulmonary edema, they present it if there is pulmonary symptom, we should always suspect a prostatic valve infective endocarditis, and we should search for any infective endocarditis lesions if at all possible. So whenever we have these predisposing factors, as I mentioned earlier, and the causative organism or any patient presenting with this non-explained symptoms or heart-related symptoms or pulmonary symptoms, you should always look into the infective endocarditis diagnosis. So to diagnose infective endocarditis, usually we do a blood culture, and then the diagnosis will be basically from the echo. It can be transthoracic or transesophageal echo. The blood culture we should take at least 3 sets of blood culture at the peak of the temperature, and at least 6 hours apart, to look for any positive blood culture or if there is any growth in the organisms. And we diagnose using a modified Duke's criteria for the infective endocarditis, which involves a major and a minor criteria. Major criteria includes the blood culture positive for infective endocarditis and evidence of any endocardial involvement, which is confirmed with the 2D echo. And then minor criteria, like a patient is having a predisposing factors like intravenous drug abuse or predisposing heart conditions, as we mentioned earlier, or if there is the temperature more than 38 degrees centigrade, or vascular phenomena like any embolic phenomena, septic embolic phenomena, or myocardial aneurysms, or intracranial hemorrhage, conjunctival hemorrhage, or painless skin lesions like genuine lesions. Next, immunological phenomena like glandular nephritis or painful knots or hot spots, And microbiological evidence like positive blood culture not meeting a major serologic evidence of any active infection with the organism known to cause infection. Those which are mentioned in the list of the causes of the infected endocarditis. To diagnose, so if there's any two major criteria or one major and three minor criteria, it's a definitive diagnosis of infective endocarditis. Or if there's any five minor criteria is meeting, then we can definitely say the patient is having infected endocarditis. And if there is any one major and one minor criteria or three minor criteria, we can possibly it could be infected endocarditis, and we should be supported with other imaging modalities like 2D echo or MRI or something like that. So echo will be the basic very important modality of the diagnosis of infected endocarditis in suspected cases. So transthoracic echo is very rapid and non-invasive, and it has got excellent specificity of almost 98%, but poor sensitivity. And obesity COPD patients, of course, they'll have a poor echo window, so it will be difficult. In those patients, transesophageal echo is preferred. It's more invasive, but and it has a high sensitivity of up to 95%. It's useful for prostatic valve assessment and then to evaluate for any myocardial invasion like root abscess or any abscess within the heart, so that we can plan the surgery, and then the intraoperative plan of the management depends on the preoperative diagnosis and preoperative clear idea where what all the structures involved.